the Shelburne Center podcast. This is Dr. Benner here for another episode and some more new content. Another JBJS article that we're going to be talking about tonight, and we have another author from one of those articles on tonight. So we'll introduce our guests in just a minute. If you want to find us on social media, you can find us on Twitter and Instagram at the SKC Podcast. We have a YouTube and Facebook page for the Shelburne Center podcast. If you'd like to email us, you can email us at the skcpodcast@gmail.com. If you like what you've heard for this episode or any of the other ones, leave us a 5-star review and a comment for those that come behind you. And also check out our previous content. We have over 40 episodes about neat topics, and we'd love it if you go back and listen to any of those.
Specifically, last week was a great episode. We had a true leader in the field. We had Dr. Liza Arendt from the University of Minnesota, and we had a great conversation regarding and centered around the treatment of patellofemoral instability. And she did a tremendous job. It was a great conversation. She has such great historical perspectives. She's been doing this for a long time, working with the athletes at the University of Minnesota and elsewhere. And she did a tremendous job discussing the exam, how to take care of these patients, as well as some surgical techniques for the patellofemoral instability patients. So go ahead and check out last week's episode to check out the patellofemoral episode from Dr. Liza Arendt.
Tonight's guest is Hassan Ghomrawi. He is an associate professor at Orthopedic Surgery Department at the University of Alabama at Birmingham. So he just joined UAB just a couple of months ago. He is the vice chair of research and innovation at UAB. He's also the associate director at CAMBAC, which stands for Comprehensive Arthritis, Musculoskeletal Bone, and Autoimmunity Center. And we're going to be talking to him tonight about a study that was recently published in the Journal of Bone and Joint Surgery titled The Cost-Effectiveness of Computer-Assisted Compared with Conventional Total Knee Arthroplasty, a Payer's Perspective. So, Dr. Ghomrawi, thank you very much for joining us, and we're happy that you've joined us on the podcast tonight.
Yeah, thank you for having me.
Very good. Well, tell us a little bit about your background. How did you get into this line of work, and how did you just were telling us off air a little bit about joining this new opportunity at UAB, and we were just curious about what your background was and how you got to this position.
Yeah, I have a slightly different sort of background than what people would usually be thinking about how I came to become an orthopedic health services researcher. When I was doing my master's in public health at the American University of Beirut, I really wanted to become a pharmaceutical economist. And I was doing this study where in Lebanon, generic drugs are not used. They only use brand name drugs. And so we did a study comparing generics to brand names and the cost savings. And I was mind blown by how much savings our economy could save by using these drugs. And so I wanted to be a pharmaceutical economist. Applied for the PhD program at the University of Minnesota, got into the program, actually did almost a thesis around pharmaceutical economics, didn't work out. I got this research assistantship with an orthopedic surgeon at the University of Minnesota. He was doing a multi-center revision knee replacement study, and I became the research coordinator for that study, learned about patient-reported outcomes, got really excited about that, and that's sort of how I got into orthopedics. I realized very quickly that there are very few people who know health services research and also know orthopedic outcomes. And so I realized quickly that I could make a big dent in orthopedic outcomes if I get into that field. And I made the shift from pharmaceutical economics to orthopedic outcomes research. The nice thing about that, although it was really painful at the time, was that I was able to act as an outcomes researcher, but also as an economist at the same time. So I could look at the same problem with multiple lenses. And then after that, I got a first faculty position at the renowned HSS and Weill Cornell Medical College, and then was recruited to Northwestern for another few years. And then a few months ago, UAB made me an offer that I could not say no to. And here I am.
Very good. Well, I appreciate your coming on tonight, and interesting background. We're getting a lot of economic pressure in orthopedics, as in all of medicine, to try to get costs down, to try to be cost effective. And at the same time, there's an explosion of technology in orthopedics as well. Wearable technology, robotics, computer assisted navigation, a lot of talk about AI at meetings and what the future is going to be with artificial intelligence, et cetera. And it's an interesting dichotomy to have the micro level stuff from at home we're all getting shaken down for cost savings, and then going to meetings and just hearing about just a broad expansion of technological resources in our field. So I think it's an interesting space that you inhabit, to talk about the economics around this and be able to understand the outcomes, because not everybody can do that. So, how many people are really looking at these things in quite the same way as you? How many of you are there out there that are looking at the economics and the outcomes and trying to put all that together in order to make some real dents in a couple different directions that orthopedic surgeons and hospital systems are trying to go?
Yeah, I don't know the universe of people who do this, but I know that there are few, because every time I go to JBJS or some other orthopedic journal with an economic analysis, it's more likely to be accepted than not. And so I think that the field is hungry for economic evaluations that do evaluate these technologies and estimate the added value to the economy of using these new technologies. It's interesting that you've mentioned sort of technology, because outside of orthopedics, I also use wearable devices on pediatric surgical patients to try to predict complications using the Fitbit data.
I do agree. I think you have a fascinating background. I'm curious, as you went from pharmaceutical economics to more the orthopedic side, did you see any parallels with that when you were doing the study on the generic drugs? And as you made the way to starting to look at this from an orthopedic lens, did you notice there were big similarities or big differences between the two?
It's not so much the similarities in the content, but more the fact that, for example, when surgeons look at joint replacement, they only, or most of them, I would say, only look at the clinical side of things. And so, but in the bigger context of things, joint replacements all of a sudden, like almost overnight, became this very highly utilized procedure that Medicare now thinks of it as a major sort of cost center, right? Almost. And they want to do something about it. And so when you're looking at generic drugs saving the healthcare system money, now we're looking at joint replacement, and we're trying to figure out ways to make that procedure save money. One thing that in my research I've looked at, and I think Dr. Banner would not totally agree with me, is the whole concept of appropriateness of joint replacement, which is sort of, let's find an objective metric to say these people shouldn't be having surgery. In the policy arena, they're saying, you guys do whatever you want. You can do the surgery. We're just going to try to lower the cost of the procedure itself. And my approach was, no, let's try to reduce the number of procedures being done if a procedure is not appropriate.
So I absolutely agree with you 100%. I couldn't agree more. We do, because we are a knee only clinic, we have knee physical therapists that work in our office. And for those listening, you can check out some of our previous content to listen to our non-surgical treatment of knee arthritis talks that we have, and which we covered in a lot of detail. And the reason is because we're trying a lot at our office to keep people out of the operating room, which I know is not something that you hear a lot of surgeons say. A lot of surgeons are saying, do you need an operation? Yes or no? And if the answer is no, best of luck. Go find something that you can do. Here's a couple of things. I think here's a medicine you can try. Here's an injection I can give. Whenever you're ready to have surgery, just come back and let me know. And our office works the complete opposite of that. We're always trying to think of what can we do to try to make you better non-surgically? How can we keep you out of the operating room? Because it's interesting when you go to meetings, they talk about how our system is going to be overwhelmed with the number of knee replacements that we have to do and hip replacements that we have to do. And yet everybody's talking about what do we do to be able to handle the amount of surgeries that we have to do. Very few people, if any, are talking about how do we avoid surgery, because surgeons don't want to avoid surgery. Obviously, our compensation, our how busy we are is all tied to the amount of procedures that we do. That's a whole other direction we could go that you could probably talk about as well, a lot about, is how that plays out with pressures from compensation being directly tied to procedures, and how that potentially affects our decision making a lot. But the point is that, I agree with you. I think that one of the ways that we handle the economics around this particular problem, and specifically, do we have enough bandwidth to handle all the arthritis and all the surgeries that we have to do, is how the hell do we find out a way to not do surgery on everybody?
Yep. Absolutely.
Yeah, the totally different way of looking at it, and probably a discussion for another day, but interesting perspective that you have there. Let's talk a little bit about the study that we're here to talk about tonight, where you compared the cost effectiveness of conventional and computer assisted total knee arthroplasty. Tell us about how you became involved in that specific topic and this specific study. What was the genesis of this paper?
Yeah, this paper is, I think, the third paper we published on the topic. The first paper was just actually the fourth paper. First paper was just review of the literature, and it was a systematic review. We looked at all the published literature, and we found that more or less computer assisted was associated with better outcomes. And then I decided to start analyzing large databases. I analyzed data from New York and California and Florida. And we looked at data over a 10-year period. We saw that there was an increase in computer assisted, but the increase is very shy, right? Over that period, the utilization increased from 5% of all knee replacements to about 10%. So although you'd say it's 100% sort of increase out of the sort of bigger pie, it's still a very small percentage. We also published another study, a very recent one, where we looked at patients from New York State. We took everybody, and then we compared computer assisted versus conventional. And we found that the outcomes of computer assisted were much better than those for conventional. And so in my mind, I was thinking to myself, there is this procedure that produces better outcomes, but then its utilization is very low. And what are the drivers of that? And so one way that I wanted to approach this was to say, are there sort of financial incentives, right? Are the financial incentives playing into this? And that's how we did this cost effectiveness study.
Yeah, I think from my general impression is that, as we talked about off air again, I'm much more into robotic assisted surgery as opposed to computer navigation, and I don't think robotics isn't necessarily akin to this particular paper that you did. Correct me if I'm wrong. That's right. This is just
it just
not robotics.
Yeah, it doesn't include any robotics.
Yeah, but I assume a lot of common themes seem to be there in the literature, that I think people agree that we can get better with alignment using technological advances to help do our surgery, and our chances of having outlier alignment are better. Are less if we use some sort of technological advancement to do the surgery. I think that is settled science that it does improve alignment outcomes. I think it is equally. I shouldn't say equally settled science. I used to think that, but I think more as more data comes out, it's at best uncertain whether or not this really gives us an outcome measure. An outcome measured improvement for our patients. I think that it probably does. But the last meeting we went to, Scott and I sat in a couple sessions about robotics versus standard instrumentation, and saw side by side, talk after talk, studies saying that it made no difference. There was no advantage to robotics and technology, and then right behind it, one that said there was. So, and especially as we've started to add in soft tissue balancing as well as alignment, for me, that's been a differentiator for me that kind of pushed me over to eventually now doing it. And now I've done it for about a year and a half, and I've probably done 300 or 400 robotic cases, then I probably won't go back. So I think it's definitely a controversial thing, and you seem pretty certain that the data that you've looked at shows some specific advantages, while others, of course, say that that's not necessarily the case. So tell us a little bit about your previous studies. I guess I'll be honest, I haven't read your previous studies, just this most recent one, on what you found.
So the previous study that compared outcomes found that the in-hospital complications were lower, much lower for computer-assisted procedures. And so when we did the study, the economic study, we made few assumptions. One assumption was that these two procedures, if you do it computer-assisted or not, the quality of life or the PROs are the same. Mm-hmm. Right? That it's not producing anything better in terms of functional outcomes. We also did the study from a payer's perspective. And I think that's the innovation mostly of the study. The one who's paying for this is the one who's going to drive this. And there's a lot of prior literature from other procedures that show that if insurance covers something, more people will use it.
No right? doubt about that.
And there's ample evidence from the cardiac surgery literature and other procedures where if insurance covers it, more people will start doing it. And so I think that's one innovation in this study that hasn't been talked about before. The other thing is that we recognize that there are two types of patients. There are the elderly patients who are Medicare patients, and these become Medicare patients and they're insured for life. And so Medicare incentives are to improve your outcomes for the long run, right? Versus commercial insurance or like something like Blue Cross Blue Shield or similar types of insurers, they cover people for a period of 3 to 10 years. And so the time horizon there is different. And so the incentives are different. These insurers focus mostly on short-term benefits, right? They don't care if you get cancer in 15 years, right? But they do care if you're insured by them and you're going to get diabetes in the next 2 years or a heart attack in the next 2 years. So the way we modeled them, we created two different models. And so we modeled with a short-term perspective, and a model with a lifetime perspective. The other thing is for Medicare too, we said that there are certain patients who are covered under a bundled payment arrangement, and there are some who are covered under a fee-for-service arrangement. And so we did the same modeling under different scenarios, and in all scenarios, it showed that the computer-assisted was more cost-effective than the conventional. And so regardless of how you turn it around, it still shows that there is a benefit to computer-assisted surgery.
Now, Hassan, when you were talking about the genesis of this study, and a lot of it really stemmed from what sounds like your previous work, and getting into the methodology of this study, now that you described those two care models, can you take just a couple minutes and describe more of the methodology, especially as it pertains to this Markov model? I know this is a very interesting way to look at the cost effectiveness and the different scenarios. So I know that was a big part of the methodology here. I'm looking specifically at Figure 1 for those that can go back and look at this JBJS article. So how did you go about that from a statistical standpoint within the methods?
So Markov modeling is a purely hypothetical theoretical exercise, right? What we do in these models is that we try to mimic the clinical course of a patient over their lifetime. So let me give you an example. A patient does knee replacement, has knee replacements, they have a chance of a complication or no complication, right? After the complication, they could get better, or they could have further complications, or the complication could lead to a revision, right? They could go for a few years and then have a revision. And so these Markov models are interesting in the sense that they try to mimic the clinical course very closely. And then we use the literature to try to then, for each sort of what we call a node, which is a probability a probability node, which is like, say, what are your chances of having a complication? right? In the literature, there's somebody who's done a study using Medicare claims, for example, and they found that probability of PE is 0.2%, right? So we use that estimate and we put it into the model. So we're trying to create a clinical course. For each event in that clinical course, we're looking at the literature and finding the estimate that we think is the best, is most reasonable estimate. And then after that, we estimate that model. And it's sort of complicated, but what it does is that it goes through these Markov models, go through a repeated cycle of events until the patient dies. So it could go for 40, 50, 60 years until the patient hypothetical patient dies. And then it rolls back and says, over these 60 years, how many quality of life measures this patient get and how much cost did this patient incur. And then we compare the treatment options based on the course of the patient's lifetime. That seems a little technical, sorry, but
No, that was very helpful.
This is what Markov models are all about.
Yeah, and I find those models very interesting. At least in my next question, one of the big outcome parameters you were looking at were the quality adjusted life years. And I know you mentioned that when you run this Markov model and you run through these thousands of simulations and you can come up and determine the effectiveness, and that was a big part of the tables that you had. So when you're comparing the effectiveness and you're looking at those quality life years, and you're comparing here with 0.82, 0.749. Can you explain how that was determined as it relates to the difference between computer navigation or computer assisted and conventional TKAs?
Yeah, so just to simplify the quality adjusted life year, it's a year, but if your quality of life during that year is lower than what we consider as optimal, then you're getting less than a 1 unit for that year. And so if you're living with a lot of disability, your quality adjusted life year is like, I don't know, 0.6, 0.5. Some people with like cancer have like 0.4. And if you die, your quality goes to 0 during that year. And so this is sort of a measure that has been developed primarily because they wanted one measure that can compare treatments across diseases. So this is sort of a much bigger conversation about like prioritizing treatment. So things like what happened in, for example, England at one point in time, where they decided that they want to look at all the treatment options and only pay for those that provide the highest quality of life, the highest qualities, right? And so we are comparing cancer treatment with total joint replacement, with vaccines, with other things. In here, what we've decided to do for these, as I said, we've assumed that these two procedures provide the same quality of life, that there's no functional benefit to computer assisted. Although I think there is ample literature out there that shows that computer assisted results in better alignment. So over the long run, you're going to have less loosening, less rates of revision. But the evidence that's right now is very controversial. And the only data that we found that has long-term follow-up on these patients is an Australian joint replacement registry. And that's where we got our estimates for the difference between revision rates for computer-assisted and conventional. And even for that, I mean, the revision rates are not a lot, just to be very frank about it. We need more registries from the US to show us this data. I think there is reason to do this study again with US data to see if the assumptions that we made using the Australian registry still hold.
So Hassan, as we talk about these results now and try to put them into context, into kind of the broader context in orthopedics, what do you think that we learned from this study, and how do you put that into context with what's known out there? And is this something that your group has gotten to the point where you think that computer-assisted surgery is something that would be cost-effective and should be broadly accepted, or is it something that still requires more study? Where would you kind of put it in context?
I think based on the evidence that we've reviewed and based on the study, I would advocate for more utilization of computer-assisted total knee arthroplasty. I mean, and I think it's not just providers, but also payers. They should, I mean, one of the main purposes of this is to tell payers, look, guys, if you pay for this, more people will use it. If you pay for this, you're going to save money. It's not just better for the patient, it's also better for you.
I can tell you what my early experience in robotics, I think that my hospital was a little bit skeptical at the beginning on how much this was going to cost and how much I was going to use it. I think they've had experiences with robots they've gotten at other hospitals within the network, I'm told, that maybe aren't utilized that much. And when I jumped in with both feet. I started doing them on 100% of my primary total knee arthroplasties. And for the last year and a half, that's really all I've done, unless there's some sort of malfunction with the robot. I'm using the robot 100% of the time. Some of our other surgeons at the same hospital are just using it for more complex cases, et cetera. And, the interesting thing was talking to our industry partners about this. They're like, wow, we just can't believe you've gone to 100% utilization from the very beginning. And I stopped and I kind of looked at them weird and I said, well, why the hell would I not do that? They're like, almost no, and I was surprised I didn't know this. I was surprised to learn they're like, almost nobody does that, Dr. Benner. Almost everybody starts by using it on 10, 15% of their patients and isn't using it for everybody. And for me, I was kind of down on the technology for a long time, but once I decided I felt like there was an advantage and something to be learned from it from a research perspective, I felt like it could make me as or more efficient, which it has, and started to see some benefits in it. I decided to go with it 100%. And I kind of wish more surgeons, if you're going to do it, I would encourage those that are thinking about it. If you're going to make this change, start doing it. And once you get comfortable with it, use it all the time and have that become your new way.
Yeah, I think you're doing it because you believe that the technology is going to improve the outcome of the patient. I think from an insurer perspective, right now they're paying for computer assisted and conventional the same way. And what we're advocating is that if this is going to save you money on the long run, why don't you pay more to the surgeon or the hospital for doing it as a computer assisted compared to conventional? The small amount of payment that's additional in the short run upfront will save you a lot of money on the back end or on the long run in terms of revision rates and other things.
Yeah, I'm glad you said that, Dr. Benner. I'm glad you mentioned the utilization. And Hassan, I really enjoyed how you and the other authors talked about the potential cost savings for the payers. And you mentioned it at the end of the methods as well as the end of the results section, and put it into context that if the utilization of computer-assisted knee replacement was 60, 80, or 100%, and you showed those values that the payers were able to save, I think that is a really great point to put in this, especially from a payer perspective, to see if the utilization was these percentages, what are we saving? And like you said, if there's some type of incentive that they can offer for that, because they know that the utilization, and the higher it gets, the more they save.
Yeah, and especially because there is an upfront cost to robotic surgery, for example, or computer-assisted surgery. But then if you as the provider feel that you're getting additional payment for this, you're gonna do it more. Just give you another example. Investing in an MRI, right? An MRI is like $1 million or so, right? Why would a hospital buy an MRI? Because MRI services are covered by insurance, right? They're willing to pay for it upfront because they know that over time they're going to recoup that cost. And I mean, we're all sort of humans. We like to make sort of the patient front and center. We'd like to focus only on the outcomes, but then there is sort of a financial system around this, right? And if that financial system or the incentives of that financial systems are not aligned, they will stand in the way of getting the patient their best outcome, right? And what we're trying to do is just to get these financial incentives aligned with what the surgeon wants to do, so that the patient outcomes are optimized.
And we're really thinking about this from strictly, I am anyway, thinking about it from a strictly American model. And it's not like that everywhere. We had Dr. Claudette Lejean from NYU on a few weeks ago talking about the ethics around denying surgery. And in amongst that, we talked about, as a part of that ethical discussion, the systems, the countries that have systems with limited resources, where this is how much you get to spend for your department for a specific amount of time. And when you're done doing the surgeries you had and run out of money, you're done until the next cycle starts. And that's not like that in the United States, but it is in a lot of places around the world. Where this kind of information that you're talking about and the cost savings associated with it has a lot more impact, maybe on a global scale than even in the United States. But if it's cost savings, Americans ought to be able to think outside the box of our, of many of our, our tenets of business that we have to spend money to make money and be able to see the long term. So I think studies like this are essential, and I applaud you for doing it.
Okay, thank you very much.
Very good. Well, what do you think would be any other take home points as we start to wrap up here on what you would want to tell our listeners about cost effectiveness as it relates to technology and orthopedics?
I think cost effectiveness analysis is an underutilized tool. I would advocate always for more cost effectiveness analysis, because they do inform decisions that are not purely driven by outcomes, but also driven by the financial incentives and the financial incentives we live with. And the more we can justify from a financial incentive or from an economic incentive, economic standpoint, that what we're doing is also saving money, I think we can continue to align the sort of the clinical objective with the financial objective.
What do you think the future is? Where do you think this is headed? If you had to pull out your crystal ball and see when we're, 10, 15, 20 years into the future, where are we? Where do you think we're going to land as we're trying to prognosticate on the economics around this issue moving forward?
Yeah, I would like to think that in 15 years, all the procedures will be done sort of with an AI perspective and using sort of computer assisted or robotic technology. But the truth is healthcare moves in a very slow pace. I don't know if in the next 10 years it's going to catch up with technology, but it's been very slow. I'll give you an example from my non-orthopedic sort of research. We've published a Nature paper in pediatric surgery developing an algorithm that predicts complications 2 days before they happen, right? That's a no-brainer. It should tell the hospital that they should include Fitbit data in their electronic medical records, right? Because the value is very high. You're trying we're identifying complications 2 days before they happen, so you're intervening much earlier.
Yeah.
Lori, the hospital that I'm in, and I know many other hospitals, still don't have this Fitbit data in their electronic medical records. We still haven't figured out how to put this Fitbit on patients and have them wear them sort of post-surgery in a systematic way. There is, and it's real, there is a disconnect between how quickly technology is evolving and how slowly healthcare is adopting it. And if we want to sort of be practical, we need to realize this gap.
Yeah, no doubt about that. I mean, if you're trying to get things to move fast, going to healthcare systems and government institutions is not exactly a way to make things go at light speed, as we all know. So, hopefully we'll keep chipping away at it. And again, thanks for your contribution to our field and to this specific area of study.
Yeah, just to further that conversation real quick, Ronnie, you mentioned the crystal ball, and Hassan, you mentioned that in a perfect world in 10 or 15 years, we'd be using AI and robotics and computer assisted navigation and whatnot. What can the researchers of the world and the clinicians of the world really do to speed that up? You talked about this disconnect. Is that, doing obviously more cost effective type studies. And we were at the Academy meeting just earlier this spring, and I saw more value-based care discussions than I really ever have, which I think is a good thing, because you're talking about potential incentives and pay for performance type metrics, which I don't know if that's the future or just the idea of value-based care in general. But my question for you is how do we speed that process up to connect that disconnect, if you will?
I'll offer my own perspective on things. I think the more collaboration between researchers and clinicians, the more closely the researcher is able to look at the clinical problem, the more the surgeon is open to collaborating with the researcher. I think more collaboration means that we get to the solution faster.
Great stuff. So, I think that kind of puts a bow on this topic. And thank you so much for taking some time out of your night to discuss this with us. It's been really educational for Scott and I, and hopefully our listeners as well. And keep up the good work. I'll be looking for future studies with your names on them. So thank you very much.
Okay. Pleasure.
Very good. Well, check out our previous content. Other than this episode, if you haven't already, we have 40 plus episodes. Leave us a 5-star review and let those that come behind you know about our previous content and what you liked. Check us out on social media at the SKC Podcast, Twitter and Instagram, and our Facebook and YouTube pages as well. And we'll see you next time on the Shell Center Podcast.